Hi, everyone. Welcome to the 2019 Brain Health Online Summit. I am Amy Zellmer, founder of Faces of TBI, and I'm a TBI survivor myself from a fall on the ice in February of 2014. And myself, along with Dr. Jeremy Schmo from Minnesota Functional Neurology Center, we saw a need in the brain injury community for more training and education on alternative healthcare methods and modalities for those who are still suffering from the lingering effects of a brain injury. So each weekday during the summit, you will hear from presenters who will share their experience either working with brain injury patients or their own real-life experience living with a brain injury. And today I am here with Dr. David Biberdorf, and he is a 1985 graduate of the Southern California College of Optometry and initially practiced in Rochester, Minnesota until 1988 when he joined the Valley Vision Clinic of Grand Forks, North Dakota, specializing in vision development, vision therapy, and neuro-optometric vision assessment and rehabilitation. He is a fellow of the COVD, the College of Optometrists and Vision Development, a member of NORA, and a founding trustee of the International Sports Vision Association. He has done research with the University of North Dakota's Dr. Dmitry Petrosky in the area of ocular motor and electrophysiological markers of concussion history, which has been published in such journals as Vision Research, Brain Injury and Optometry, and Visual Science. This concussion research has been cited in such journals as Neurosurgery and the Journal of Neuro-Ophthalmology. He is also the clinical director of Advanced Neurovision Systems, which is a state-of-the-art research-based visual assessment, rehabilitation, and training program intended to help restore neurological function of the visual system following traumatic brain injury, as well as to improve visual performance of individuals with suboptimal vision function. So welcome to the summit. I'm so excited to have you here.
Pleasure to be here. Yeah.
You know, I think this topic is just so important. I mean, as you know, they estimate that 90% of people who hit their head have visual problems. Not just acuity of the vision, but a broader problem with the visual system. So I'm really happy to have you here and share your knowledge. And those who've watched the summit in the past have seen Dr. Deborah Zielinski, and you're a similarly trained doctor in the NORA realm. So I'm going to kind of let you take over, and we'll see where this goes.
Well, you hit the nail on the head there in that we're not talking about many times acuity or eyesight. That's not what it's about. Vision problems mainly from head injury, although it can include eyesight, have to do with function of the visual system. And that means it has to do with eye tracking and eye teaming. That's a big part of it. Or the timing of the visual information, how we interact with our spatial world, all these little features. And so what I thought I'd talk to you a little bit about is how neurooptometrists understand the visual system and how that differs from, let's say, a basic eye exam that you go to down the street. On a basic eye exam level, basically what the eye doctor is looking at is acuity or sharpness of vision, the optics of the visual system or refraction, and eye health. They're just making sure that the eyes and the muscles are working in a gross sense, that there's not a muscle defect, for instance, like a palsy or a muscle paretic muscle, things of that nature. Or that there's no glaucoma or macular degeneration, things of that nature. And so many patients, unfortunately, when they've had a head injury, are sent to an ophthalmologist or an optometrist who is not really familiar with the armamentarium that's available for optometrists. And they're looking at a basic eye exam, and because it's so basic, they miss things. So what I like to tell patients who have had a head injury, there are certain screeners. And I'm going to go through some of my toys so that the audience can learn some of these screenings so that they know what are the higher levels of processing that we want to investigate? So one of the things, here's how I didn't start learning this stuff. I acquired this over time. I started working with injured athletes, basically at the University of North Dakota, mostly hockey players that were at a high level of performance. Things were going fast and things are going, there's a lot of information to process in a short amount of time in a hockey game. And I get these athletes who were concussed and they passed their neurocognitive tests. In most cases, it's the impact test. And the trainer would say, you know, something's not right. They're watching their teammates play and they're getting sick watching them skate around on the ice. So they'd send them over to me and I'd start finding out, yeah, there's some issues here. They're really having issues. Or maybe it was in the classroom where they were getting headaches just from reading. They couldn't keep up with their classroom work. And so that's kind of how I got into working with concussions and head injuries, mainly from the athletic field. And it's just kind of blossomed in the last 5-10 years where we're seeing patients who have been out 5-10 years with a concussion or head injury, and nobody has really addressed the vision issues that have persisted since their head injury. So what I thought I'd do is kind of go through some of the things that I do as an initial screener when I have an athlete or anybody in with a head injury, and what I think is becoming more and more the standard of care, what should be going on here. And any profession, any discipline can pick up these tools and you start using them tomorrow. So basically what I like to do when I have a patient sitting in the chair or coming in and at the front desk, I like them to fill out this form. And this is called the Brain Injury Vision Symptom Survey. You can get it downloaded online at the NORA website, but it's a 28-item checklist to tell us what is the problem. And it's subdivided into 8 different areas: visual clarity, visual comfort, doubling of the vision, light sensitivity, that's a big one, dry eyes, another big one, depth perception problems, peripheral vision problems, and reading problems. Those are the areas that it likes to analyze. And I think that's a good way to start. And if you get a score of 32 and above, meaning you're having some persistent problems in these areas, that's significant. It's highly correlated with history of brain injury, okay? So that's my first one. And then sometimes I'll say, you know, they passed that, but the reading area is really what's bugging them. And so there's another questionnaire I like to use, and it's called the Convergence Insufficiency Symptom Survey, CISS. And it's more specific to reading, the eye movements and everything involved with reading. So those are the basic ones I start with. Now, I talked about your basic eye exam, and it's being mainly refraction and eye health and making sure the muscles work okay. But above that level, one of the things that we need to realize is that we have a bunch of efferent or eye movement disorders that can occur from head injury. And there's 3 main eye movement disorders that can occur from a head injury. One is a disorder of vergence, which is your eye teaming, your eyes going in or out. If you look far, your eyes go apart. And if they look up close, they go in. And it's these oppositional eye movements that can be disrupted, either the speed of processing or the accuracy of processing many times is anomalous, let's put it that way. The next set of eye movements have to do with parallel eye movements that are going in the same direction, not the opposite direction, and they can be subdivided into saccades, which are the quick ones, looking back and forth very quickly, and those are the ones that you use for reading, and pursuits, which are the slower but smoother eye movements following a moving target. And those can very often be disrupted from a head injury. And that can affect reading and performance, particularly in sports and things of that nature. And then the third eye muscle dysfunction that can occur from a head injury has to do with a little muscle inside your eye called the ciliary muscle. and its ability to focus from far to near, and its ability to sustain focus. And what patients don't sometimes realize, and many doctors don't realize, is that little muscle that controls focusing, it's also tied into these eye teaming muscles, so that whenever we focus up close, our eyes are pull in automatically. They're not a separate entity. And so sometimes when we see an eye teaming problem, it's because of a focusing problem, and vice versa. Okay, they're connected. So that's called the oculomotor system.
What about a nystagmus? Where does that fall?
That can be another oculomotor dysfunction, where neurologically there can be this tendency for the eyes to wiggle. They won't fixate straight. They have a tendency to wiggle or jerk, and that's a whole another network of neurological dysfunction that can occur. And so you add that to the whole eye teaming thing, and yeah, you've got it. It's complex.
And you just hit it. It's so complex. And what are some things, like, I know how I felt. Like, yeah. I knew my eyes weren't okay. And like I said, the eye doctor, the neuro-ophthalmologist, the neurologist, they all told me my eyes were fine, which in theory, my eyes were fine, right? They weren't damaged. But like, for me, it was my left eye that wasn't turned outward, I think is what it was.
Yes. Yes.
And it just felt like something wasn't right. And my left eye is my dominant eye. So I think that's why, and I'm a photographer, so I'm much more in tune with my eye. So I think that's why it was so obvious to me.
Yep.
And when I would go to sleep at night and close my eyes, it felt like my eyes literally started moving around, which I later learned was a nystagmus, right? So what are some things that a patient might be feeling and not understand that that's their eyes?
Well, many times there's this misunderstanding that if you have an eye teaming disorder, it may always be double. No, that's not the case. Not always is there a double vision. You mean? Yeah, double vision. Sometimes there can be just this shadow image, or this feeling that there's a trailing flicker behind things that I'm looking at, or a shadow image behind it, or just a flutter, let's put it that way. Some patients will characterize it as that. And even the physicians who are testing for eye teaming, there's a common test called the near point of convergence test, where they'll take a pencil or a pen and slowly draw it in, and the patient is supposed to follow it as they're moving in. And they should be able to bring that pencil as a single image up into about 6 centimeters before it goes double. Well, many times the doctor will do it just once, and they'll see them do it, and they'll say, "Fine, you're good."
Yeah,
but
that's what happened to me.
Yeah, they don't take into account how much energy did it take. I mean, if you're instructed to do things, you want to do it, so you're putting a lot of energy into doing that, and you may be able to do it once, but do it 2 or 3 times, it may not be sufficient. And so one of the tests, and one of the things that your viewers might want to know, is that there's something besides double that can alert a doctor or a patient to a dysfunction of the eye teaming or convergence mechanism. And that's called a convergence, fixation disparity. A fixation disparity is a slippage on the retina that occurs when you're looking at a single target with each eye, but there's a slippage, that there's not a perfect alignment. It's not double. Their eyes are still aimed in the general direction, but there's a slight misalignment. And there are tests that we can use to pick up a fixation disparity or find out if there's a slippage, and it can be a valuable addition to this near point of convergence test. And there was a doctor in Chicago and my colleague at the University of North Dakota. We did some research with hockey players at the University of North Dakota, and we used a new test called the near point of fixation disparity test. It was much like a near point of convergence test, but it used a different target. And I'll show it to you if you're interested. And what we did, this is the target. The target looks like this. It has an arrows pointing at a letter E. Both eyes see the letter E, but the patient they're supposed to wear these Polaroid glasses. And these Polaroid glasses, they're unique in that the right eye sees the top arrow and the one to the right, and the left eye sees the bottom arrow and the one to the right. But both eyes see this center target, okay? And if there's a fixation disparity, what the patient will say is, yeah, I see one letter E, but the arrows aren't lined up. There may be one higher or lower than the other, or they're misaligned just slightly. And what we decided to do, Dr. Lederer in Chicago developed this test, is they bring this target in very slowly while they wear these glasses, and the patient, instead of being asked, when does it go double, they're asked, when do those two lines start misaligning? And so we did it with hockey players at the University of North Dakota. We had their histories. These were all asymptomatic athletes, but we were able to discover who had had a past history of concussion based on this test. Because if their fixation disparity occurred beyond 15 centimeters, they were 10 times more likely to have suffered a past concussion. And it told us two things. One is this is a very sensitive test. But another thing it told us is that sometimes after a simple concussion, and we say you've recovered, you can play, there are still some residual oculomotor dysfunctions that they may not be aware of that are still there. So it's an interesting thing that we found.
That's kind of amazing.
It is amazing.
That's really cool.
So this is a cool little test, and Dr. Lederer, God bless him, he's worked with this for years. He even built a different one, which are kind of a smaller version of what we just talked about, but they're spaced in such a way that it mimics the eye movements one makes with reading.
Wow.
And so I use this as a provocative test. So I have the patient put these on, and I just have them look at this, and I said, can you just call out the numbers and then tell me if they're lined up whenever you move your eyes? And many times, all you have to do is pull this up, and the patient goes, oh, get that away. That's my provocative test. It tells me there's an eye teaming problem. We don't have to do any near point of convergence or any other test. That's diagnostic in and of itself.
What is that test called, if anyone listening is interested?
The test that I showed you that's approaching you is called the near point of fixation disparity test. This one is called the Polaroid saccadic near point test or something to that effect. But if they email me and you can give them my information, I can send them where to get that. But it's a great little tools.
That's awesome.
Yeah. So those are just some tests that we use for the vergence system, for the oculomotor vergence system. Some of the tests that we use for pursuits and saccades are more sophisticated. I use an electrodiagnostic test that utilizes eye tracking, remote eye tracking on a computer. The system I use is called Right Eye. And it can trace what your eyes are doing when you're following a moving target in a circle or moving your eyes back and forth in a saccadic manner. And I like it because it's kind of like your sophisticated roadside sobriety test. I mean, it really can help diagnose things very quickly. And I have some examples if you're interested in seeing what a readout looks like. I don't know if your viewers can see this, but this is an example of a person who's pretty good at tracking here. I hope you can see this. The top over here shows you good eye tracings of a circular moving target. And then below here is a vertically moving target. These are vertically moving targets and vertical saccades and pursuits. And everything lines up pretty good. But here's a patient
like
that.
Yeah, there you go.
Somebody who comes up and you're going, uh-oh, there's something wrong there. They're trying to trace that with their eyes, and they're just not tracing things or making their eyes move efficiently. And so these are nice little ways of being able to pick up things that are rather subtle to eye care practitioners or anybody else who's seeing a concussed athlete.
You know, I know Dr. Jeremy uses the Right Eye But
Yeah,
it's so validating to see it. And he also uses the VNG, like he goes a lot deeper
it
with
really
that.
is validating. Yeah.
But it's so validating as the patient, like, oh my God, I'm not crazy. Like there is something going
There's
on.
something going on here. Yeah.
And when you see that, when you see how
Yeah.
they're so jagged, like it's no wonder you feel dizzy, you're off balance, you run into the doorway when you think you've got 2 feet,
Yeah.
like it makes so much sense to see that.
Yep. And what we like to see, or what we like to think, is that how much energy did it take for them to make this jagged problem? They're taking all their attentional, something that should be pretty automatic. It's not that difficult, and they're taking all this energy and they're stealing it from their cognitive levels or their attentional levels, and they're having to do these rudimentary, basic things. And after a few hours of that, no wonder patients who have a concussion are so fatigued.
Yeah.
And we can't assume that they're just, well, they can do this, they can read, that we put them in these situations where they have to perform, and they just can't. And so that's where remediation comes in.
I just had a totally random thought, but like, that right eye results, showing them to a teacher, right?
Yes.
So you've got an athlete, or I mean, it doesn't even have to be an athlete, someone who was in a car accident, fell off a bike.
Yep.
You show that to a teacher, and it's like, this is why they're having trouble reading, focusing, staying alert in class. Like, for me, when we got the eye tracking stuff, I was 2.5 years out before I found Jeremy. We got my eye tracking stuff cleared up. I mean, over the next 6 to 8 months, my memory improved, my fatigue improved. Because like you said, your brain is using all its energy to try to help you just like navigate the world. So
it's interesting how that it is. Now we do have another eye tracking device that we like to use as kind of a tool for readers. It's called the Visograph, and it kind of looks like this. It's got these little sensors. They have to strap this little pair of goggles on. But what they do is they read these passages, and each passage is normed. So you can compare your eye movements with everybody else, the same grade level or whatever, and you can determine if their eye movements are performing for the reading task specifically, like they should. And this will record things like how many forward eye movements they made, how many regressive eye movements they made, how well their eyes were teaming, how long they look at a word. And one of the more fascinating things about head injuries is that last part, how the duration of fixation, or how long you look at a word, seems to be much longer than patients without a concussion. So that's one of the features that we're really interested in is what does it do to your reading performance? And that seems to be the big one. They look at words much longer than they should. There's some theories why.
What was that one called again?
Duration of fixation. Oh, that's Visograph. The Visograph. Yeah. So it's another tool that we use. We have all kinds of tools. I'll show you all kinds of.
This is fun. I love show and tell.
Well, another tool we like to use, I like provocative tools, something quick and dirty to see how a patient performs. And one of these is actually used with migraine patients, but I use it for my concussed athletes or concussed individuals, something like that. And I can see you look away. But this is a good one because it says, I just have them say, looking at stripe patterns, does that irritate you? And if they cannot tolerate that, you know that there's something in the visual sensory mechanism that's not performing well. And there's some theories of what's going on there. So there's actually some theories that looking at these patterns can create some trigeminal nerve disruption and create the whole headache cascade that we're familiar with migraines. So it's an interesting list, a quick screener. So those are good ones. Another quick screener I have, actually this is more diagnostic, is this is a critical flicker frequency device. This is highly correlated with patients who complain of photosensitivity or fluorescent light. They see the flickering of the light or their computer screen. So it's kind of a cool little test where basically what you do, there are two buttons back here. One is you have the patient hold in a button and you'll see this flickering going on, and it gets faster and faster and faster. And when it becomes a perfectly steady beam of light, the patient just basically releases their finger. So as soon as it becomes a steady beam of light, they release their finger. And then the opposite is they have a steady beam of light, which very, very slowly begins to flicker. And when it begins to flicker, they release their finger. And then it averages that score, and we can figure out if their brain is hypersensitive to this flickering sensation. So it's a nice way to do it. We also have something that we're doing research with is a pupillometer. After a head injury, many times the mechanisms of pupillary responses are changed so that the pupillary constriction and dilation dynamics to a flash of light are altered. So we use this pupillometer that they hold it up to their eye, there's a flash, and it measures the speed of response of the pupil mechanism to a flash of light. And that can be help in diagnosing concussion head injury.
And do you do both eyes? Like, I'm just curious if sometimes one is more affected than the other.
Sometimes we see that, yeah. But in most cases, it's both eyes are the same. But we do see these asymmetries once in a while. Let's see, what other toys did I bring? Like I got all these little things here. One of the things that we're doing research in, if you're interested in that, we do a test called visual evoked potential. Basically, visual evoked potential is setting up some electrodes to the visual cortex and stimulating a patient's central vision. And actually, there are two pathways of the visual system that we're interested in. One is our focal vision, our central vision, and one is more our ambient vision. And the speed at which it is received by the visual cortex should be pretty close to the same for both of these pathways. Well, we came up with a way to try to separate these two pathways, test the speed of each pathway, and compare the speed of each pathway to find out if there's a sluggishness in the speed of response of the brain to visual stimulation. So we use this this is just an example of the patterns that we use. The top two patterns are flashing at a rate of twice a second, and they're meant to tap into our focal processing, focal pathway. And our ambient pathway, which is more automatic, let's put it that way, we don't have to think so much about it, that's being tapped into by these sinusoidal waves that are low contrast, but flashing 4 times a second. And we compare the speed of response. Both of these should be around 100 milliseconds. If anything, the ambient processing is just a little faster than our focal processing. What we've discovered is that with a head injury, it's the ambient system, the automated system, that's delayed, sometimes even up to about 40 milliseconds. And that timing delay may explain why patients with head injuries are more sensitive to light. Motion sensitivity, is going into a grocery store and having these motion processing problems, walking down an aisle and having this sensation like, I got to get out of here. This may be one explanation for why that happens. So.
Yeah. And that's, I think that's the hardest thing for other people to get is that whole, I kept being told I just have positional vertigo. And I was like,
yes.
This isn't positional vertigo, And like you said, you're walking down an aisle and it's almost like the aisle's kind of moving.
Yeah, it's like, am I moving? Is the aisle moving? What's going on here? Exactly.
Yeah. Or you might stop, but then it still kind of feels like you're moving.
Boy, yeah. It's really disorienting. So hopefully this will give you an example of some of the tools that we're using. It's not the total battery, but some of the tools that we're using to try to basically take the visual system apart bit by bit. And then once we understand, okay, this is what's wrong, try to get the patient involved in some rehabilitation, maybe individually to begin with, but then combining all these visual processes so that an efficient visual system can reemerge after we know that the visual system is plastic, that it's just like any other system with persistent training and repetitive use, that we can build this visual system up again and maybe make that visual system more automated so that we're not stealing from the cognitive attentional areas so much. So,
I've kind of explained it like we're born knowing how to use our eyes. We don't have to teach ourselves how to use our eyes.
Right.
And when you take a hit and they go off course, you don't know what's wrong.
Right.
And you don't know how to reset that.
Right.
And you need someone like you or Jeremy, who understands it. And, for me, the exercises themselves, I mean, they sucked at the time, but they're virtually really easy things to do. Like look at a dot and move your head up and down or whatever. Right. And I mean, it really didn't take long to get my eyes working together again. And, I still have issues on occasion, and I'll sit down and do my exercises. And
I think I was trying to think of an analogy the other day of what this is, what you're going through, what's going on here. And here's the way I think of it. I went to Europe about, 8 years ago, and I visited these relatives in Germany that didn't grow up speaking English. They grew up I'm German from Russia, so they grew up in Russia. They didn't learn English. So I went to visit them, and I was with them by myself for 10 days. And they're speaking German. I know a little bit, but I'm not that fluent. And honest to God, I think my third day I was ready to leave. I was like, I love you people, but I hate you. By noon, my head was hurting. It was like, you're going too fast. You're just going too fast. I can't keep up with your speech, your language, and then I can't retrieve the right word and the right tense, and it was just so overwhelming. But I did get better. In 10 days, I learned. My wife came to visit me about 10 days later, and I found myself having trouble speaking English, getting back into the English mindset. And so I look at the visual system after a head injury. It's going to find its way, but it's going to be inefficient.
Yep.
And what we're trying to do is go back to relearn that efficiency of the visual system, so that things are flowing just like you're saying, you were born with this. This is how you should be. So that's my analogy.
So somebody listening who is struggling, what would be your recommendation on how to find someone like you if they're not?
Well, there are several places to go, and one is NORA, N-O-R-A, Neuro-Optometric Rehabilitation Association. I can't remember their website offhand.
I think it's Nora Vision Rehab.
I think you're right. NoraVisionRehab.com, I believe. And it's a great resource, but any discipline can join NORA and learn more about how that visual system fits into their own model of concussion health. So, but it's a great resource, and that would be the place I would go to. Another place that would be helpful is covd.org. COVD is the College of Optometry and Vision Development. That organization has doctors who are interested and are knowledgeable in vision therapy. And both organizations are very, very good at helping you find a provider who can understand how to test and how to train these areas.
Awesome.
Yeah.
Any final thoughts?
I just think what you're doing, Amy, is so good, because I've learned from watching your videos about other disciplines, and we get kind of locked into our own discipline. Yeah. And so, what are they doing there, and what are they doing? It's really helping everybody, not just patients with. And all I can say is that doctors, to be a clinician, you have to keep an open mind and start learning. And I think it's wonderful that if you can find a clinician who's willing to learn and collaborate with other disciplines, that's the way to go, because concussion and head injuries this is something medicine just cannot get their arms wrapped around.
Agreed.
And we're making discoveries all the time. So it'll be interesting to see what discoveries come about. For instance, I'm helping out a hyperbaric oxygen clinic, just gathering data at what is hyperbaric oxygen doing to the oculomotor system. It's some fascinating stuff. So I think just keeping an open mind is kind of nice.
Yeah, and it's such an interdisciplinary approach. You know, it's not just one person's going to help you.
Right.
You know, it's going to be multiple providers, and you know that's kind of exactly why we're doing this. I have a ton of patients watching, and we also have a lot of clinicians watching, and so you know, if we all just work together and to help the patient, okay, like if you can't help them, here's somebody who can, right? And just having that relationship is so important, just really building up the TBI community. So thank you for what you do.
You bet. Take care.
Awesome. And thank you everyone for watching, and we'll see you all in the next episode.